Greetings, everyone, and welcome to the Science of Childhood Cancer lecture series hosted by the St. Jude Comprehensive Cancer Center. I'm Seth Carroll. I'm a pediatric oncologist and an assistant member here in the Leukemia Lymphoma Division at St. Jude. It is my great pleasure today to welcome our speaker, Dr. Mignon Lo. I've had the pleasure of collaborating with Mignon since my hem-onc fellowship here at St. Jude. Dr. Lo received her AB cum laude in the history of art from Bryn Mawr College before receiving her MD from Columbia. She then completed a pediatrics internship from UCSF before completing her residency and pediatric hematology oncology fellowship at Harvard and Boston Children's Hospital. She was a research fellow at Brigham following her clinical fellowship, and then returned to UCSF as an assistant professor and rose through the ranks there, and is now a ladder rank full professor and holds the UCSF Benioff Chair and Distinguished Professor of Children's Health and the Deborah and Arthur Albin Endowed Professor of Pediatric Molecular Oncology. She served as the chief of the Department of Hematology Oncology since 2013. Dr. Lo is a highly sought-after speaker and has been well-funded by the NIH and private foundations, and has published more than 225 peer-reviewed manuscripts. Nationally, Dr. Lo served as the vice chair for biology for the Children's Oncology Group's Acute Lymphoblastic Leukemia Committee from 2007 to 2015, and has been ALL committee chair since 2015. There, she exemplifies leadership and what she's termed team science to lead the committee in practice-changing clinical trials. Dr. Lo will soon leave UCSF and will move to Seattle to become Division Chief of Hematology, Oncology, Bone Marrow Transplant, and Cellular Therapies, as well as Director of the Bentown Center for Childhood Cancer Research and Section Chief Pediatric Oncology of the Hutch. It is now my privilege to pass the stage to Dr. Lo for what I'm certain will be an excellent talk.
Thank you for that lovely introduction, Seth. That's a lot. That's a mouthful. Thank you so much to the organizers for inviting me to give this virtual lecture on one of my favorite topics that keeps me busy. And I entitled it, it's a little bold, but I entitled it, what will it take to actually cure every child with acute lymphoblastic leukemia? Because we're pretty close, but we're not quite there yet. And, I think that there's still a substantial burden of late effects that our patients do experience. So, as a committee chair for this incredible group, it's been a wonderful honor and privilege. We think about some of these questions as we plan our clinical trials. And so what I'm going to do today is I'm going to give you an overview of what we're currently doing with our clinical trials, and then maybe introduce a few things that we're thinking about for the future. So I always start my talks, if anybody else has heard me speak before, I generally start it with an iteration of how well we've done over the decades to cure patients with acute lymphoblastic leukemia. And I know that Dr. Pui has the same iteration for all the total studies that St. Jude has conducted. And I think that it's been a remarkable success story, which is great, but we're still not, we're still not at 100%. And we still do see our survivors experiencing some late effects. But we do pretty well. And when you look sort of in hindsight about the survival improvements we've seen over the past 20 years, I'm going to be mostly focusing my discussion today on B-ALL. But when you compare sort of T-ALL versus B-ALL, when I was a first-year fellow in 1995, I was taught that T-ALL, it was more difficult to cure those patients. And now when we look at more recent outcomes from our studies, patients with T-ALL are almost at the same survival rates as patients with B-ALL. And these really represent substantial reductions in death rates. And in fact, given the fact that slightly more African Americans are affected by T-cell ALL, this improved survivorship in T-ALL likely helps to explain the improved survival for African Americans over the past 20 years. And this is actually also shown here, where we are demonstrating that we are narrowing the racial gap, which is awesome for at least African Americans. And so, we're doing pretty well. What has improved the outcome over the past 5 decades? Well, we had to recognize that the CNS was a sanctuary site that required focused therapy, and that was the major advance in the 1970s. We then augmented traditional chemotherapies in terms of dose, schedule, and combinations. And then we developed modern risk stratification. We recognized that groups of patients with higher relapse rates may need more therapy, and those tend to be those patients who are older, over the age of 10, patients who present with higher white blood cell counts greater than 50,000 per microliter, patients who are slow to respond to our first month of induction therapy, and then certain genetic subgroups that carry prognostic significance. I do want to remind the audience, for those of you who are not ALL sort of clinicians, these are the traditional chemotherapy agents that we still largely use in our trials, regardless of whether you're treated at St. Jude or in a COG, ALL institution, or even the Dana-Farber. But look at the year that these were all approved by the FDA. These are a lot of old drugs, and they are certainly effective. But I think we're looking for more, and I'll tell you a little bit more about that in a few slides. So why do we continue trying to improve outcomes? We're almost at the top there. And I would say that we do this because relapse remains a high burden for this most common of childhood cancers. So as an example, despite their overall better outcomes and the fact that NCI standard risk patients are more common, so it's usually 2/3 standard risk, 1/3 high risk, they actually contribute to about half of our treatment failures. So for every 1,000 B-ALL patients, there are about 77 events among NCI high-risk patients and about 73 events amongst NCI standard risk patients. So it still remains a certain burden for those patients with relapse. And also, the question is, when we think about improving outcomes, is it possible to consider, maybe we could test a decrement in therapy, and would that also improve outcomes by reducing late effects? So these are some of the things that we continue to think about. Just to review, survival is much worse after relapse. I expect these curves are probably going to shift over the next 10 years as we've had, the introduction of these novel immunotherapies. But the most recent data would indicate that survival is quite bad after you relapse, especially if you relapse close to your first diagnosis. So this was an older paper that I was a senior author on, where we looked at patients who relapsed between 1988 to 2002. And for those patients who relapsed less than 18 months from their initial diagnosis, just in the marrow, their survival rates were dismal at about 11% at 3 years. This data has now been updated by Deepa Bhojwani and Sue Reingold. And we're doing a little bit better, but I would still argue that, these sort of 30% survival rates at 5 years for patients with early relapse remain unacceptable to us. And as I said, I think that in the next 10 to 15 years, certainly, hopefully after I retire, somebody will take another look at the data and we'll probably see that it's actually improved with all of our newer therapies. But for right now, this is where we are. We also know that when we look at response to the first month of induction, otherwise known as minimal residual disease, we know that we can identify patients for whom intensification of traditional therapy fails. So this was a really interesting study. This was 0232. It's the study where, we know a lot about the genomics, given the collaborations we've had with individuals at St. Jude. We also know a lot about their response. It is the study that essentially has set the standard of care to use high-dose methotrexate for patients with high-risk ALL. But what we did in that study, and it was the first time we actually used MRD at the end of induction to actually intensify therapy for those patients who had a high MRD, as well as some other sort of bone marrow findings, but we don't have to talk about those. But what I wanted to point out was that we intensified therapy for the patients here in the yellow curve. So if they had an MRD greater than 0.1%, they received a double delayed intensification and more therapy. And for a little while, they did pretty well. Sorry, my arrow's not working. But then at 3 years, they started to plummet their outcomes. And that, to me, to many of us, said, maybe just intensifying traditional therapy is not going to be the key to improving their outcomes, and we'll have to look for other ways to treat them. And then we also know, in addition to patients who respond poorly to induction, that certain patients who belong to subsets of ALL, such as infants or hypodiploid ALL, still have poor outcomes. So, when you comes for a closed mature study, AALL 0631, which was just infant ALL, and you looked at their overall outcomes, they still don't do very well. Largely, this is because of the KMT2A rearranged patients. The germline patients do pretty well, actually, but we have not moved the needle for infant ALL in decades. Nobody has, and I know that Dr. Gruber's doing an outstanding job of testing some of her strategies as well in the infant protocol that is sponsored by St. Jude. And then we also looked at hypodiploid ALL. And again, this is a harder analysis to do because we actually took those patients off of our frontline trials, but at the time, but we still did look at their outcomes, and we collected the data as best we could. And we found that neither chemotherapy nor hematopoietic stem cell transplant was favored in the treatment of these patients, and found that when they had poor responses to induction, they did quite dismally. Again, this was all collected retrospectively. It was before we had very sensitive metrics to measure minimal residual disease burden before transplant, et cetera. So there are lots of frailties with this data. And I, of course, know about the publication from St. Jude on some of the outcomes from their patients with hypodiploid ALL, but I certainly think that we'd all agree that they certainly do not fall into a favorable risk group. So how about this idea of intensifying cytotoxic chemotherapy? So if you needed further proof that, we just don't think we can actually do more with the drugs that we have had in our FDA-approved toolbox for so many years, these are some actual clinical trials that support the fact that more is not better. So we tested the addition of a second interim maintenance and a DI in CCG 1961 or CCG 1991, and it didn't lead to improved outcomes. And much of this data has been published, actually. So I'm just sort of quickly summarizing this. We looked at whether Decadron for 2 weeks versus prednisone for 28 days for patients who are over the age of 10 years would improve their outcome. And actually all it did was lead to more osteonecrosis. And so that study was amended to just use prednisone for patients who were over the age of 10 years during induction. We tried to intensify consolidation on our standard risk trials. Rather than just give them a month of essentially maintenance therapy, we gave them the 2 months of augmented BFM backbone, and it didn't work. And I was pretty surprised at that outcome, but it did not work to improve outcomes. We added additional PEG asparagase to patients who had a favorable risk, standard risk ALL. That didn't work. We tested clofarabine, etoposide Cytoxan in 1131. We found that basically introducing clofarabine, even in newly diagnosed patients who had achieved remission, was highly toxic. We had to close that study twice, and we had to finally abandon the clofarabine question because of the toxicity, and that's been also published. And then we also kept the etoposide cyclophosphamide control arm open on 1131. And found that it also did not improve outcomes beyond what our standard augmented BFM consolidation does. We tested methotrexate, oral methotrexate, 40 milligrams per meter squared versus 20 in maintenance on the standard risk trial 0932. Didn't make a difference. And we also tested intrathecal therapy with triples versus singles on one arm of the high-risk 1131 trial. Didn't make a difference. And then finally, we did most recently test whether or not Q12-week pulses of vincristine and Decadron decreased the event-free survival compared to the standard Q4-week pulse, and found that actually there was no difference in outcome. And so we've made adjustments to our frontline trials to actually incorporate some of this work. But I think taken together, it just, again, demonstrates that intensifying traditional chemotherapy is likely not going to work for any subset of childhood ALL, at least in B-ALL. So all of this begs the question is, when is it time to stop asking conventional chemotherapy intensification questions in ALL, and what therapeutics are available? So we already know, and I know that many of you are highly aware of this data because you helped to generate some of this data that I'll talk about in the next few slides. But we do know that the addition of tyrosine kinase inhibitors to chemotherapy backbones improves outcome substantially for BCR-ABL positive ALL patients. And I would venture to say that it is quite standard now for people to be treated with just chemotherapy and TKI rather than automatically assuming that they're going to go to stem cell transplant. Certainly, we do reserve transplant for patients who have poor responses to our early therapies, et cetera. But this data from Kirk Schultz's trial, AALL0031, has held up very nicely and has also been published and shows that there's a 7-year, 71.5 essentially disease-free survival compared to a historical control of about 20 for patients who are not treated with TKI. So again, we know that when you find the right target, it can make a difference. And so, of course, many of you in the audience have been intensely involved with the collaborations between COG, Target, the Pediatric Cancer Genome Project, which obviously was inclusive of St. Jude because St. Jude drove that, with some of the sequencing efforts that have been performed on these large number of patients, both enrolled on COG trials, as well as those enrolled on St. Jude trial. And I'm not going to, go over a lot of this data in detail because much of it has been published, but just sort of explain how we've actually incorporated that into our current trials. And at the end of the talk today, I'm going to talk about another project that we're just finishing up that I think is going to be also very relevant to how we design our clinical trials. I sort of put this in because I want to acknowledge the collaborations that we've had with investigators at St. Jude and just thank you very much because they've been such a privilege and honor to be part of. All right, so lots of people on the bottom of this slide have been involved in generating this data, and this really looks at the spectrum of kinase alterations in a group of ALL patients that we determined to have pH-like gene expression signature. And so this is, again, probably review for many of you, but at the end of the day, more than 70 different fusions have been identified that involve at least 19 kinase cytokine or cytokine receptor genes, as well as sequence mutations or structural alterations in a number of these genes, CRLF2 primarily, but also IL-7 receptor, FLT3, SH2B3, and of course, our friend RAS. And of course, what's interesting about these lesions, at least for the fusion genes, is that many of them are predicted to be targetable by, imatinib, dasatinib, ponatinib, et cetera. And these are what we call the Abel class lesions. And then we also have sort of the JAK-STAT pathway lesions, which may be amenable to the introduction of ruxolitinib, again, both on the backbone of chemotherapy. Sorry, I don't know how to go back. Okay, so this is just a sort of a list of the frequency with which these arrangements actually occur. And then, yes, pH-like ALL is associated with constitutive activation of kinase signaling, and Catherine and others they have shown that elegantly in a number of published papers. And here's just a quick look at like how this changes, how the sort of the incidence of these lesions change between sort of the traditional pediatric AYA demographic versus the older adult. Again, much has been published on this with people from this audience. We also, of course, looked at the outcome of these patients, these pH-like patients versus non-pH-like patients on that sentinel trial 0232, and not surprisingly found that patients who had pH-like ALL just had poorer event-free and overall survival. So, for us, this was the first example that we could actually use to introduce a somewhat complicated genetic risk stratification algorithm to incorporate into our clinical trials. And this is spanned from AALL 1131, which is the most recently closed high-risk ALL trial, to the new trial, which is AALL 1732, which I'll speak about in just a moment. But the algorithm essentially that, people in the community, when they have a new patient with high-risk BALL, they send samples to Nationwide Children's, where Shalini Reshmi and her crew perform just an RNA extraction, send that over to the University of New Mexico to Rick Harvey and Emain Cheng, and they actually run an LDA card to see if they're the leukemia cells are pH-like or not. And then once they're identified to be pH-like, a series of additional tests are triggered that identify the specific rearrangement for CRLF2 or the JAKs, as well as additional details based on sort of these results for the determination of an Abel class fusion. And so at the end of the first month of our induction therapy, we should have all of the information back on anybody who's pH-like, such that if they are positive, they may be able to shuttle to one of our two precision medicine trials, if you will. And that's AALL 1631, which is enrolling pH-positive patients and now Abel class patients, versus 1521, which is enrolling a cohort of patients who overexpress CRLF2, who are also minimal residual disease positive at the end of induction. So if that sounded like a mouthful, it is. And I think that that's one point that I wanted to sort of make, is that this precision medicine and, this algorithm to identify these patients, I just explained it in about 2 minutes, but it took many, many months to optimize. And it really has created a lot of opportunity for our patients to get great next-gen sequencing performed, but it also is complicated. And I think that we can't kid ourselves about the complexities of introducing precision medicine technologies. And so here are the sort of recent clinical trials for patients who have PH-like ALL, including the one that we still have open, which is AALL1521, led by Sarah Tajan. You have some of these patients also treated on Total 17, and then there's another University of Chicago trial that's ongoing and continuing to enroll. Okay, so certainly TKIs are going to be additive probably to chemotherapy for certain patients. It's a minority of our patients, though, and we also don't know the outcome yet of using ruxolitinib with traditional chemotherapy. So what else is there, and how do we get them into children? So when we think about our strategies, do we find that we can ask questions for all of our groups? Well, not really. So some of our most favorable groups have outstanding outcomes, and it's unlikely that an intensification of therapy is going to improve those outcomes even more. So the question is whether we can declare victory for some. And I don't want to be so cavalier that we'll always declare victory, but maybe these are patients for whom we can actually decrease a little bit of therapy and see if we can maintain those excellent outcomes. But for most patients, we're trying to improve outcomes. And so we've talked about how we've been targeting using targeted therapies for genomic subsets. And then next, I wanted to talk a little bit about how we've incorporated immunotherapies, for lack of a better term, to our frontline trials. And we've done that by introducing the agents and the strategies based on two factors. One was the established risk of relapse from our prior studies, as well as the risk of the actual agent. Like, how much do we know about this agent, and do we feel comfortable exposing this set of patients to that agent, knowing the side effect profile? So these are the three that we're testing. Blinatumomab, which is a bispecific T-cell engager that it redirects CD3 positive T cells to CD19 positive blasts. Inotuzumab, which is an antibody drug conjugate. It's raised against CD22 and it's conjugated to calicheamycin. And then we also have a CAR T cell trial, which is a living biologic, and everybody knows about CAR T cells. So this is the distribution now of our current frontline trials. And again, I'm only focusing on B because T could be a completely different lecture. So for our 1731 trial, we enroll patients with standard risk ALL, and during that first month of induction, we get their somatic genetics and their response. And for those patients, who have, ETV6 rungs 1 or double trisomy, and they respond well, this is all going, to induction, there's no randomized intervention. So they get standard of care therapy. We then move the wheel over to the standard risk average population who have neutral cytogenetics, also essentially favorable MRD responses. And they can be randomized to blinatumomab if they have essentially the presence of a high throughput sequencing MRD signal at the end of induction. They're all flow negative, but in another sort of kind of complicated algorithm, but it seems to be working very well. We actually identify these patients who are MRD flow less than 0.01 at the end of induction. And if they don't fit into the standard risk favorable arm and they don't have features of high risk standard features, we actually have an algorithm where they get their diagnostic banked sample and the end of induction sample sent from Nationwide to Adaptive in Seattle. And within about 2 weeks, we know if they have a clonal sequence to follow from their initial diagnosis and what that result is at the end of induction. And so for those patients who are positive with HDS, but again, remember that they're negative by flow, they're getting randomized to receive 2 cassettes of blinatumomab monotherapy that's intercalated into chemotherapy. And then we also have a very small fraction of patients who present with standard risk features, so young, low white count, but don't have the best response to MRD. And for those patients, they also end up getting randomized to blinatumomab, but they also get the backbone of high-risk therapy added to their treatment. And that's all on 1731. We spin the wheel over again to the high-risk trial, which is 1732. And again, we have a very small slice of patients who have favorable genetics and respond super well to therapy. But so this is like the kid who is 10 and a half, so is NCI high risk, but low white count, has ETV6 rungs 1 and responds great to induction. by definition, he's eligible for 1732 because of his age. But for those patients, we do not have a randomized intervention. The majority of our patients are treated with high-risk ALL on the inotuzumab randomized arm. That's 1732, and they will get randomized to 2 blocks of inotuzumab, again, interspersed amidst the chemotherapy. And then we have 2 more trials to discuss. One is 1721, which is for patients who have persistently positive end of induction and end of consolidation MRD, and these patients are eligible for receiving a CAR T cell product in first remission. And then we have a precision medicine arm, which I spoke to you about in detail, with the 1631 and the 1521 for the ABL class and CRLF2 JAK-STAT altered patients. And so just putting this in a slightly different tabular format, this is the wheel that I just showed you. These are sort of color-coded with the groups that are receiving this therapy here. So we have the standard risk and high risk favorable who have a projected 5-year DFS of greater than 95%. They don't get an intervention. We have standard risk average and high that get the blinatumomab randomization. We have the high-risk trial on 1732, and they get the inotuzumab randomization. We have a non-randomized study to enroll patients with persistently positive MRD for CAR T cells, and then we have our molecular targeted therapy. And then I will say one departure, sort of wholesale, that we're not testing in these current trials, specifically with a randomization, is that all patients on 1731 and 1732 are receiving every 12-week pulses of vincristine and steroid, and that all boys and girls on 1731 and 1732 are receiving therapy for 2 years from the phase that starts after consolidation. And for those of you who treat ALL patients, you'll know that this is a departure from our prior trials, where we actually would treat boys for 3 years from essentially interim maintenance 1. Dave Tichy published a nice review of sort of why we wanted to do that in Blood. I think it was 2020 in August. So I would recommend that you read that if you have questions about that. And then finally, I did want to show very quickly. So those patients I talked about who are eligible for the CAR T cell trial in first remission are those people who remain persistently positive with end of consolidation MRD. This was updated with 1131. They may not do quite as poorly, but this was very impressive to us when we were planning the study. Again, this is our 0232, that Sentinel high-risk trial. And when you had patients who actually had persistently positive MRD at the end of consolidation, their 5-year disease-free survival was about 40%. And so we thought that these patients justified a more intensive approach. I think it's become relatively standard of care to take those patients to transplant, but we felt like if we could spare 50% of these patients from going to transplant because they responded well to their CARs, that would be a big win. And so that resulted in this 1721, frontline trial for using Kymriah, Tisagen-Lechleusel in CR1 ALL. And again, the target accrual is about 140. And it's open not only in the United States, but also in Europe. So this actually then is just a survey of the open trials that we have for our frontline patients. And unfortunately, we will not have time to talk about relapse because that could also be a whole nother hour to discuss. But these are the trials that I just sort of reviewed. And we also are continuously developing trials on the committee. And so these are the next trials that are coming down the pike. These are all concepts that have been seen at least once by the Scientific Council and are in progress. So we have a frontline infant ALL trial that we will use venetoclax in. We have, and that's led by Rishi Kotecha and Aaron Brees. We have an upcoming pH positive and ABL class trial to open after, probably simultaneously with 1631 closing, but that's being led by Ty Tran, and we hope that'll be an international trial. The T-cell upfront trial, we hope will test the efficacy of daratumumab, and that's also in development. And then we have a relapsed infant trial that will test the efficacy of the menin inhibitor in patients with KMT2A rearranged ALL. Very important to our frontline trials is actually a number of embedded trials that we are also testing in 1731 and 1732. And these will help us understand the impact of our care embedded studies. So impact of our care, and these are the embedded studies. Sorry, it's a run-on sentence. Okay. So we have household material hardship and neurocognitive outcomes that these are being assessed on 1731. In Hardy and Iris Paulton. Study that's looked at symptoms in children who are with the following investigators here, including Julianne Brackett, Sarah Alexander, Naomi Winnick, and Abby Rosenberg. We have a really important study that's being led by Lisa Giacola, who's from St. Jude, on the longitudinal assessment and quality of life outcomes in Down syndrome patients who are enrolled in 1731. We didn't have time to talk about how they're being treated on 1731, but I do want to just punctuate this lecture by saying I'm quite excited about the Down syndrome patients because we're actually substituting a month of intensive chemotherapy with a third block of blinatumomab because we know that Down syndrome patients are at higher risk for morbidity and mortality with our chemotherapy intensive approaches. And then for 1631 and 1732, we have an important adherence objective, which Smita Bhatia is actually running, and there's a really elegant ability to participate in adherence enhancing interventions. So not just like, oh, you should take your medicine, but oh, we're going to remind you to take your medicine every day if you participate in this trial. So we'll see how that all works. Okay, so this lecture was like, what's it going to take to cure everyone? And I'm not being that bold, but I'm interested in this, and I think, I'm very proud of the trials that we're currently running, and leading this group has been just incredibly privileged, a privilege for me. But I do think about this, like, where do we take this next? I'm grocery shopping, I'm making the bed, whatever. Like, what's it going to take? And so one thing that we've been working on is how we might consider further refining risk stratification, and also how we might identify relapse drivers of diagnosis. So this was a presentation that a very talented grad student in statistics who's working with John Kerala and Minnie Devidas, and she's at the University of Florida, Natalie Del Rocco, has been working on with several of us. And we have been meeting probably twice a month to work on this data set. So as people know, we enroll a tremendous number of patients on our COG ALL trials. And, I never want to waste one patient. Like, that would not be ethical. And so I want to use as much data from these patients as we possibly can. They're on these clinical trials. We have a lot of genetic data about them. We have a lot of response data. So we grabbed the patients from a number of protocols, and I'll explain how we did that. And we wanted to see if we could refine and enhance our risk stratification beyond what we're currently doing, and maybe think about how we might implement that for the next generation of trials. So I'm going to talk a little bit about why we did this and how we did this, and love to get your thoughts at the end of the talk. But again, all of the statistical work has been done by Natalie, and I'm just kind of explaining it, I hope. So it's in two parts. The first part is, externally validating the United Kingdom's prognostic index, and I'll go into that in a moment, and determining whether our additional value of day 8 peripheral blood minimal residual disease helped refine that model. And I'll explain what I mean in just a couple of slides. And then the second part is, how can we actually use this data to more to risk stratify patients with an even finer tuned dial, if you will. And how does that compare to what we would otherwise be doing today on 1731 and 1732? And then finally, what are the potential uses in future trial planning with these algorithms? Okay, so the first part is how we looked at the UKPI and added the day 8 peripheral blood MRD. So I showed you this curve at the beginning. Like, we do really pretty well, but it's not enough for those patients who fail therapy. And the one thing I would just point out is that our modern risk stratification is built upon categorical values. So we lump patients into groups to receive therapy after induction that we think balance relapse risks with the intensity of therapy. And the risk categories that we use, which I alluded to before and sort of explained before, are standard risk versus high risk. So you have to be between the ages of 1 and 9 or over the age of 10. You have a presenting white count less than or greater than 50,000 per microliter. You get somatic genetics, a slew of somatic genetics measured, not super comprehensive, but the basics. And then you also get minimal residual disease, essentially using flow cytometry in the peripheral blood on either day 8 or bone marrow. That's kind of the global way we do that. And the issue is that when you use categorical variables like presenting white count, just this threshold, or minimal residual disease, greater than or less than 0.01, it sort of diminishes the power to refine your risk stratification. And so our colleagues in Europe, and this was led by Anthony Moorman with a paper, beautiful paper in JCO by, I think it's David O'Connor and Amir Enshai, in Blood, they actually further developed, or they actually pioneered the idea that, we could develop a different, sort of more personalized risk stratification if we just took a couple of the variables and used them as continuously log transformed numbers. And so we looked at this paper in great detail, and we applied it to our B cell patients. So we didn't look at T cell status. But what the British authors did is they identified all the univariate risk factors for risk stratification. And then they further refined that by taking the significant ones and distilling them down using a multivariate modeling structure to generate the least number of these variables that would significantly contribute to this prognostic index. And they took these coefficients with their statistical mapping, and they created a linear equation to actually develop something they called the prognostic index. So this is the PI. So I'll just refer to this as PI from now on. And what they demonstrated in the JCO paper and now in this one is that the PI correlates with the risk of relapse. Okay, so here is the risk of relapse. And they did this first in the UK studies and then also applied it, and that was the discovery cohort. And in this particular paper, they applied it to several other cohorts of patients who were treated in Europe. And they ended up with kind of a low, standard, intermediate, and high risk group. So this was really interesting to us. And given the fact that we had so many patients that we might be able to sort of replicate this in, we were really interested in doing that. And so the question was whether COG had the data to validate and extend the PI from the UK. And so we took patients that enrolled on 4 consecutive BALL trials. 0331 was the standard risk trial that was the companion to 0232. 0932 was the next generation of standard risk trials, and its companion was 1131. We did not include Down syndrome or Ph positive patients. And so we were left with still a large number of patients. I think it was over 20,000. But we did then parse them out into risk groups. And we called our risk groups a favorable risk group. This is genetics, ETV6 RUNX1 or double trisomy of 410, versus unfavorable risk groups, which is URG. So that was the KMT2A rearranged patients, IAMP21 patients, hypodiploidy, and then everybody else was in the middle with intermediate risk groups. And then we log transformed. So we also took these continuous variables. We log transformed the presenting white count, and we also transformed the day 8 peripheral blood MRD. So it's now a tau day 8. That just stands for the log transformed day 8 peripheral blood MRD. And then we also log transformed the day 29 bone marrow MRD. So that's the tau day 29. So these are the patients that we actually ended up putting in this model. So you see, again, this usual demographic of 2/3 standard risk patients to 1/3 high risk patients. This is the breakdown by sex with female and male. And these were the genetics that we ascertained from the clinical database. And this exercise actually gave us an opportunity to really solidify our cytogenetics database as well. And so you have your favorable risk group, your intermediate risk group, your unfavorable risk group. We had some that did not have available data, and so they probably didn't go into the model. And then we had a little bit of information on pH-like. I'll just point out, you're not seeing anything that we wouldn't have expected. Patients who had standard risk ALL there were a much higher number of those who had favorable risk genetics versus patients who had higher risk disease, so not a surprise. And so what I wanted to point out here, which is not intuitive for people who are seeing this data for the first time, is that the higher the tau MRD, the lower the actual MRD. So, this is a lower value, but it's a higher MRD, and it's because of the log transformation. So, again. Okay, so we applied the PI UK, so we took their coefficients and we just applied it to our COG data just to see what would happen. And so these were the the prognostic index values for these patients in our COG data set. Here are the standard deviations. And what you can see, first of all, to explain, is that the lower the PI UK, the lower the predicted risk of relapse. Okay, this is bucketed by favorable risk genetics, intermediate risk genetics, and unfavorable risk genetics. So, for example, a patient with a PI UK of -1 has a twofold risk of predicted relapse compared to a patient with a PI UK -2. So, just to sort of let you see how we actually were looking at this data, because it certainly was not intuitive to me. But what was interesting is that, I'm really interested in those patients as a clinician. Like, otherwise, they would have been in the favorable, genetic group, but there's clearly a whisker with skew here where there are some patients who are not going to do as well. They're going to relapse. And the same thing can be shown, well, the same thing can be shown for the intermediate risk group as well. So then in this particular panel, we then actually did the same sort of transformation with the coefficients in a multivariable analysis, now including the tau, the log transformed peripheral blood on day 8, and we came up with our own linear equation. And so this then got plugged into our data, and we looked at the coefficients, and again found out that these were very prognostic for outcome. So again, these particular patients are going to have a higher risk of relapse than these patients here in the genetic risk group. And so we sort of recapitulated how our own developed PI from COG data could actually be very similar to the UK PI, but even better, when we looked at how this data parsed out now with the incorporation of day 8 peripheral blood MRD, we can look at the data basically in two ways. One is we can look at the distribution of the UK PI by NCI risk group. Okay, so there's a standard risk, here's a high risk. And then we can actually, and that's just using their linear equation on top of our data. And then we can look at our linear equation where we come up with a COG PI, again, by risk group, and we can overlay that on our data. And then you can see immediately that there's a group of standard risk patients that seems to be more obvious compared to the standard risk patients that are actually predicted by the UKPI. And so when you actually look further, what we think is that, our COGPI may actually allow potentially, if you squint your eyes a little bit better discrimination of some of the standard risk patients who actually might do better versus those who might have an increased risk of relapse. So remember, the prognostic index moves to the right with the higher risk of relapse that you have. So the part one summary is that, we validated that we could use the British prognostic index to predict relapse by applying just their linear equation on our patients, but then further developed our own PI using using larger numbers of patients and also including the tau day 8 MRD. And it did add significantly to the model through discriminating between hazard ratios of the favorable risk group genetics and the unfavorable risk group genetics. And finally, I just showed you that the COG PI, we feel qualitatively at least, still working on this quantitative aspect, but qualitatively identified more distinct groups that could identify patients with a higher and lower risk of relapse. So then we wanted to extend this. So that was presented at ASH last year, and then over the year we've been refining this. So the question is, how can that be used to maybe update our risk stratification, and how can we then apply it? So this is from the NSHI paper, and again, it just gives you some examples about for some patients with certain clinical scenarios and how they each fit into their personalized prognostic index. And so you have the highest risk patient here who, has a low white count, but has a high MRD and has a high risk cytogenetic feature and is at the highest risk for a relapse. And so we wanted to see if we actually could improve upon that as well. So is there a more intentional way of defining risk groups based on a continuous prognostic index? So Natalie spent a lot of time doing the analysis. We talked a lot about the kinds of treatments that were received, and there was a lot of attention paid to whether or not, are we overtreating some patients, et cetera. And the other question is, can we achieve more granularity with fewer risk groups by using the full continuous information? So currently, our COG risk stratification on 1731 and 1732 identifies 7 risk groups. So these are the ones: standard risk, favorable, average, and high risk, favorable, high, pH-like, and that should be very high risk. In contrast, the UK group predefined 4 risk groups: low, standard, intermediate, and high. So we were just kind of working towards, like, let's see how we can actually further use this in maybe a new risk stratification model. So in order to do that, we had to do a couple of different steps. The first thing we had to do was we had to study, or Natalie had to learn, how we are classifying patients who are enrolled in our current trial that I spoke about before, 1731. And so this, you shouldn't, just think of big picture and squint your eyes, but this is basically the risk stratification algorithm that we use for patients on that trial, and these are just the variables. So not super important for you to know about, but just know that this risk stratification currently is a little bit updated from what we used for the previous trials. And we also sort of updated it a little bit for 1732 as well. This is what we're using for the 1732 trial in terms of risk stratification. So again, it's an algorithm of risk group and extramedullary disease, maybe some cytogenetics, and end of induction MRD. So what we did then is we took all the patients that were on those legacy trials, 0232, 0331, 0932, and 1131, that we used to generate the COGPI. And Natalie reclassified them to how they would be classified if they were to enroll now on 1731 and 1732. So these are the 7 risk groups that actually exist on the 2 open trials. And I would just say there's a fair amount that are not applicable because we didn't routinely collect AA peripheral blood for all of the patients on those legacy trials. So that's why some of that data is missing. Okay. So, and you can see, though, it pretty much, comes out to what we might expect in terms of, 0932, this is a standard risk trial that's closed and mature. We had half of those standard risk patients actually fall into the favorable risk group. That's totally in line with what we thought. We had a few that were in this sort of hybrid favorable average, which I won't explain because it's just a couple of patients. And then, the majority, again, are between standard risk average and standard risk high. So this is nothing super surprising. Just want to remind you, though, that, when we actually take the PI and distribute the COG prognostic index amongst these patients and try to do that with the prognostic index, we, again, broke them down into 4 bins. So how low, standard, intermediate, and high. So how do we reconcile, like, what they would have been risk stratified on had they enrolled on 1731 and 1732 versus this legacy and this retrospective PI from COG? So, let's just take that data. Let's say, okay, well, you did the COGPI on all those patients. How did they turn out in terms of favorable, low, intermediate, standard, and high risk? And boy, it parses out really quite beautifully when we do this by the COGPI. So this is just, the patients who were given a number for the COGPI, where they landed in the 4 risk groups and how they did. And that's pretty darn good for how we look at some of these survival curves. The high risk patients, as predicted, do less well than the favorable risk patients. So then what we did was we took those patients from those legacy trials. We had applied the current risk stratification to them. So we had all of where they binned into. And then we looked to see how they parsed out with the COGPI. So now this is the COGPI with the low, standard, intermediate, and high. And this is how they would have been risk stratified for standard risk favorable. And this is just the incident numbers. Again, we have a large number of patients who we couldn't do this for because they didn't have their day 8 peripheral blood. Okay. So what's really interesting, I think, about this, these are some animations that Natalie had in here. What's really interesting when you look at some of the work is that some of these risk categorizations actually do change. So, for example, these patients would have been standard risk favorable. Most of them continue to be in the lower risk PI for the COG prognostic index, but actually 10% of them are in the standard risk group now. And so I think it's interesting when we think about how some of these groups have shifted, that we'll see in the next slide how that actually parses out to outcome. And I might also just look at the high risk group here, because you can see that there are a number of patients here that have now actually been subsetted into low, standard, intermediate, and high using the COG-PI. And so in point of fact, this is where it gets really interesting. When you actually then break this down, this is our COG risk classification for sort of how we're doing it now. This is the PI sort of reclassification, putting it into low, standard, intermediate, and high bins. You can actually see that for the standard average patients, we have a range now of patients identified with this more continuously based risk stratification that goes from about 96.9 to 88.6. And even perhaps more interestingly, for the high-risk patients, again, we have some patients who are doing super well with our current therapy at 94%, but now there's also a group of patients who are not doing as well when they get reclassified by the COG-PI, and that's to 68%. And so, the challenge that we have when we're designing our trials for the ALL group is that we need to make sure we achieve a meaningful statistical question with sufficient sample size and power to actually feel confident we're going to find an answer. And Steve Hunger taught me a very long time ago that unless you have a hazard ratio of like at least 0.65, it's going to be hard to prove a benefit. So when we think of distributing these patients, maybe these patients, and we can design a patient that might just focus and improve on this outcome 0.5, because when you lump them all together, it may get lost in the whole signal. And so I don't know if we're going to be able to use this. I hope we can, but it's something that, I've been thinking about how we move to more adeptly refine our risk stratification for future trials. So the other thing that I sort of introduced the idea for was, could we refine our risk stratification? I just talked to you about some of the sort of statistical scientific work that we're doing to explore that. The other one is, can we identify drivers at initial diagnosis beyond the somatic genetics that we know occur that might actually help us figure out, for example, who's the ETV6-RUNX1 patient who's going to not respond well to our therapy? How can we identify them to preempt and not allow that patient to relapse, et cetera? So we have another project that's ongoing called the Molecular Profiling to Predict Response to Therapy, and that's called the MP2-PRT. And again, Charles, Gang, Chung Shu, and Ti Chang are all involved with this, alongside the COG statisticians and a number of other investigators. And that was a contract that we received from the NIH where we could study 1,500 patients with banked samples available for a question. And the question that I wanted to ask was, could we design a case control, so a 1 case to 2 control study, where we did a genomic survey of essentially standard risk patients, some high risk patients with favorable genetics, but mostly standard risk patients, to identify significant alterations at diagnosis that would predict relapse. And so the NIH paid for all of the sequencing. I'll show you the schema of the workflow, but we basically have been working now for about 1.5 years on doing this analysis. And I'm going to show you just a hint of some of the data, but we have more to go, and I'm really excited about this project too. So essentially, this is the basic sort of workflow that we've been working under, and that is, the NCTN Biospecimen Bank nationwide, the Statistics and Data Management Center. We identified the samples to be pulled. They extracted the nucleic acid, and they sent it to the Broad Institute for whole exome and whole genome sequencing. And these were contracts that the NIH had set up, and to UNC for RNA sequencing. We negotiated having all of the data downloaded to the bioinformatics team at St. Jude, and have had sort of monthly calls, sometimes more frequently, to start taking a look at the data. And ultimately, it will be uploaded to the Genome Data Commons and ultimately also available to the research community. The cohort of the COG patients studied, so this is the final sample number. So these are from 4 of the clinical trials. You'll recognize these names. You'll probably see where I'm going at the end of this presentation with this. But we looked at the number of relapses. We stratified by MRD negative, MRD positive, and we selected cases who relapsed and their controls. And this is the total number from each study. So more than, 80 or 90% of the samples are actually from standard risk patients. So 0331 was a standard risk trial and 0932 was a standard risk trial. And then we just had a few from high risk, but they had favorable genetics. And I sort of did this because we had so much information over the years generated from NCI high-risk patients from COG that I thought it would be very interesting to see what we could find from the standard risk population as well, given the data that I showed at the beginning that said that standard risk patients actually contribute to half of our events that we see every year. So in summary, curing ALL remains the goal for a large number of pediatric, adolescent, and young adult patients. But, we always ask, what late effects price does this occur? I think I've shown you that intensifying chemotherapy is not going to work any longer, and that testing new agents and technologies is a major priority for our ALL trials, and that the embedded outcome studies will strengthen the impact of our trials. Finally, I hope that I've shown you a little bit of data that demonstrates that improving outcomes might require a new approach to risk stratification, and a little taste of the genomics work that we're doing to identify significant subtype-specific alterations that affect relapse risk. So just wanted to send some acknowledgments along. Directing the COG ALL committee is a little like me being Fred Flintstone in an orchestra, but it's been a great privilege and one of the biggest honors of my life. And these are the acknowledgments, with extreme gratitude, of course, to our patients and families. So with that, I know I'm sorry I'm a little bit over. I really wanted to try and squeeze in some of that information at the end, but I'm happy to take some questions if there are some. Thank you.
Thank you, Mignon. That was a fantastic talk. Since we are at the top of the hour, we can go ahead and close the formal session, but thank you again for agreeing to stay on for questions afterwards. For the group as a whole, thank you all for coming, and we'll be back next week on October 28th when Dr. Martin Poole from University College of London presents on CAR T therapy for childhood cancer with the University College London experience. And with that, I will jump into the questions that came in on the chat as you presented. So the first comes from Jun Yang, and had a question regarding the PI, and specifically regarding the index. He noted that the age was not included as part of the formula, although the other half of the traditional NCI risk, the white count was, and so wondered if you could comment on that.
Yeah, no, that's a really great question, and we're having another meeting with Natalie tomorrow. We've talked a bit about that, and so that is, she's sort of working on that dimension. This is definitely still a work in progress, but yes.
All right. The next question was from Dr. Relling, looking at the genomics case control study in the lower risk patients. What features were the cases and controls matched on in terms of therapy arm, time on therapy, ancestry, MRD, all these other factors that we know may influence the risk of relapse?
Yeah, that's a really good question. I'd have to look back at my notes. We did control for some things, but we didn't control for everything, because otherwise, even in our big data sets, it would have gotten really small. So we did control for MRD. We did also look for genetics, and we also we couldn't look at ancestry because we just didn't have a lot of genetic ancestry, because most of it is actually standard risk patients, so it would have been self-declared, and we did not extend that because that data is also a little messy. So we mostly did, I think it was, I have to double check, I thought it was sort of age, I know it was MRD, and genetics.
Fantastic. When you think about the prognostic index, do you see that as further changing the way patients go on trial, or how do you anticipate using that in future studies?
Yeah, so so Natalie's also developing like this app. Actually, it's amazing. She showed it at the COG meeting, where not the patient and not the treating physician maybe can actually plug in all of their variables, and then it spits out all of the data about what we know based on our legacy COG data to come up with a risk with a PI basically. I don't. That would be so amazing if we could do that for the study chairs. But I think that if we could, and it will be hard. There's so many variables that play into this because, the high risk trial is not going to close for a while. It just opened to the second safety phase. The standard risk trial has been enrolling like gangbusters, and it's going to close probably in a couple of years. So we're starting to plan the standard risk trial. I'd love to use this again at the end of induction to see if we can refine risk stratification because you need that first month to find out how they respond and what their genetics are. But I'd love to see if we can think about how we do that. And it's just going to be a challenge because we also have a brand new intervention, a Blina, for the standardized patient. We don't know how that's going to affect things. And so, we're sort of, the wheels are sort of turning and we're seeing how we're going to be able to do that. And it could be that we actually use it for a decrease in therapy question too. Like, are there just patients that are so good? Can we risk that? And that also will be a discussion that we have to have.
Question from Ernesto Diaz-Flores about the use of off-the-shelf or allogeneic CAR T therapy in clinical trials.
Oh, I think, that's currently, that's probably more a question for the relapse setting, but absolutely. I mean, I think that we're just wading into the water, if you will, for newly diagnosed patients for CAR Ts and only for those patients who have the highest predicted risk of treatment failure. Because we don't know very much about the long-term side effects of CAR T. Every day we get a little bit more information, but we still, when we were designing that study, we just didn't know very much about, how long, thought it'd be tolerable. Can people be celluloplastic? The immunodeficiency literature says lots of people stay on IVIG for a long time, et cetera. So I don't think we're ready to do this in frontline quite yet, but undoubtedly, I bet in multiply relapsed patients that there probably will be some forays into that.
I've got one while we wait for any more that come in. So the current relapse trial looks to replace that first induction block with blinatumomab for patients that are very high risk of failure or have had high toxicity. And you referenced during the course of your talk the toxicity associated with frontline therapy. Are we at the point in the next generation of trials where we start to replace some of these really intensive blocks with some of these more targeted agents, or are we still trying to inch that curve up a little higher by intensifying therapy with novel agents?
Well, I can't speak for my entire group. I think that those agents like Blina, I wish Blina didn't have to be given 24/7. It was just a little easier. That'd be so awesome. But I think that we're in an era where we will be incorporating some sort of question of that. Again, when you design, as when we design clinical trials, we're always looking for the most recently mature outcomes, right? So we won't have the Blina outcomes for a while. The question is, do we have so much data on the fact that it's so well tolerated that we could justify it as well? So we're thinking about that. And we've had lots of discussions also amongst senior members of the ALL crowd who say, introducing new agents obviously is important, but don't forget that standard risk therapy on COG backbone is not awful, right? It's 75 milligrams per meter squared of doxorubicin and couple doses of, whatever, dose of Cytoxan, whatever. And that's true, but it's just but is it necessary, right? So how important is it to get that potential risk of having fever, neutropenia, sepsis even? So I think the next phase of analysis is also going to have to incorporate, balancing toxicity. That's one thing, but also how many patients would parents will people be willing to risk for relapsing, based on the fact that we can probably salvage more of them now with our therapies like CAR T cells and blinatumomab. Are we getting to a point where we're really looking at overall survival as opposed to event-free survival? Can we tolerate, but what is that number? Is it 5 for every 1,000 patients? Is it 20 for, so I think those kinds of analyses are just starting to be done actually. And so we'll kind of come up with numbers and we will have to meet with our parent advocacy groups to see what they would want. What would you say if your doctor said, well, we're going to decrease your therapy. We think that's going to result in maybe 5 more patients relapsing in the next 10 years. that might be okay for some people, but that might not be okay for others. So that's sort of how we're thinking about it. A very long-winded answer. Sorry.
Great, thank you. Question from June about combinations of chemotherapy with immunotherapy, and thinking specifically about sequencing and how our immunotherapy and our classical chemotherapies interact, specifically whether our chemotherapies make it harder for immunotherapy to work by weakening the immune system and dampening that effect.
I think that's an outstanding question, June. To date, we mostly have data from, our relapse trial, which I'm sorry we didn't have time to talk about, but, intercalating blinatumomab with chemotherapy or substituting blinatumomab for chemotherapy in subsets of patients with relapse who are at much higher risks of, infectious toxicity, et cetera. And there's no question that it's more efficacious and it decreases the toxicity compared to the chemotherapy. How it works when you combine it with chemotherapy is a little also not as clear. And I think we'll learn a lot from the current trials. But I will just point out, we were not anticipating some things that came up in 1732 with the inotuzumab cassettes. And we have just reopened that study to a second safety phase because during the first safety phase, so we took 50 patients, we randomized them after consolidation. So 25 got the inotuzumab block, 25 got the essentially got the chemotherapy block without the inotuzumab. And what we found was like in the first dose of high-dose methotrexate, following that block of inotuzumab for those patients that got it, they actually had delayed clearance of their methotrexate. And Pfizer hadn't heard of that. They looked back in their records. We had absolutely no reason to suspect that was going to happen. So, June, I think that's an excellent question, and I think we're going to learn quite a bit about how this all plays out from these clinical trials that are ongoing.
I'll give just one more minute for any other questions. A question from Hassan Omar with thoughts about how to intensify therapy or chemotherapy in low-income countries.
That's really a great question. I'm not really prepared to answer that. I have to be honest. It's not something that I am well versed in. I think that just one thing to note is that I think that people do largely believe that many of us do overtreat our patients currently, and that we can probably get away with lower intensity treatment. But again, for us in COG, and I'm sure at St. Jude, we're just still focused on making sure we don't make a decision that will affect a lot of patients in the wrong way. And so I just am not as familiar with the many of our second and third world countries have in terms of, therapies that are available. Like, I will never forget, I was at, and it was in the early days of imatinib and dasatinib. And it was still more economic for people in developing countries. I hate the word developing. I hope that's not politically incorrect, but people who are in under-resourced countries to treat them for a long time with TKI versus just going ahead to do the transplant. Because it was actually more economic just to do the transplant, because they didn't have the drug available. So I'm just not the best person to ask. I'm sorry. It's a good question, though. It's an important question.
I think our questions have slowed down a bit. So
Okay.
I will just take the opportunity to thank you one more time. This was fantastic. And good luck with the move in the future.
Thank you. Thanks, everybody. I really enjoyed it. Thanks. Bye.
Thank you. Take care.